Alright guys, so we are now at the part where we're going to go through NBME 21. So I have a bunch of videos up for most NBMEs lately, 18, 20, 22, 23. A lot of people have been requesting NBME 24 also, which I'm working on right now, so I'm putting the explanations together and whatnot. But I've had NBME 21 ready for quite a while, I just never got around to actually making a video for it. So here we are, we can finally get started. As usual, every video is going to be about 25 questions, so 200 questions, 8 videos, and we'll be done with all of NBME 21. It just makes it easier for me to get through it. And I haven't really been streaming after work on most days because I feel like I'd be really drained out, but I feel pretty good today. And this is different from actually teaching first aid. I'm going to be reviewing something that I've already looked at. So it shouldn't be too bad, right? So let's just kick it right off. NBME 21, question number 1. As usual, remember the page reference I have here is for my own edited first aid, which I am selling. So you can always contact me through my email. It's usually at the bottom over here. Reach out to me and you can grab a hold of it too. The new thing I did was that I did add in anything that was from anything from First Aid 2020 is now in my first aid. So for example, this thing here about phase of drugs like this, I've added over here. I'm going to be editing a couple more things, right? A lot of brand new things that were in First Aid 2020, I've moved them into my own first aid. It was easier than editing all of First Aid 2020 all over again. So saved a lot of time by doing that. There were a few nice new images like this page, right? So this entire page, this one right here, see, I labeled it as 582.5 because this page is something from First Aid 2020. I like the way they broke it down, gave more about the clinical presentation, and they have a basic little image here that wasn't there in First Aid 2019, for example. And so a couple things like that. There wasn't too much in First Aid 2020 anyway. But yes, any page references I have here are usually for my own first aid. And then I'll show you in first aid, if the explanation is relevant to first aid, I'll show you in first aid what the correct explanation is and how you would know what to pick. And one last point, as always, remember NBME is very different from UWorld, right? So UWorld is trying to teach you. So if they have a question, they give you everything in the symptoms. They give you the CTs, x-rays, all the symptoms you could possibly have, everything, because they want you to know the full clinical picture and then be able to pick the right pathophysiological answer choice. In NBME, they're not teaching you, they're testing you. So they give you the minimal information necessary to be able to come to the best and most likely answer choice. Because of those two things, best and most likely, you can often have two answer choices that do look very viable, right? Two answer choices that can both possibly actually be true. But you have to pick the one that's the best answer choice and the one that is most likely, right? So if everyone's most likely to do one thing and not get affected by the other thing, even though the other thing does seem like a good answer choice, the one that's most likely is always the correct answer choice. All right, so let's get going. Number 1 over here says, a 24-year-old man with a history of drug abuse has nausea, rhinorrhea, hypertension, and tachycardia. The most likely cause is withdrawal from which of the following agents? Okay, so they are, at least in this question, being nice enough to tell you that this is a withdrawal symptom. Right? That's something that they've done. And then when you look at the symptoms, it looks like whatever's happening, like hypertension right there is one thing that's related to alpha-1 receptors. So something here must be doing something to alpha receptors. Nausea is very non-specific. You can get nausea from anything. Rhinorrhea, though, that's a special one, right? So a runny nose, almost like a flu-like symptom presentation right there. So this is pretty much a very classic presentation for opioid withdrawal. However, they were not very, but they were slightly more confusing in this question. Remember that these tests always know that the language barrier between different countries is a huge deal, right? In America, we all know heroin, but in other countries, opioids are just opioids, and heroin is not really something you discuss as an opioid per se. But you cannot get all these other answer choices. This is definitely not an alcohol withdrawal thing, right? You would see delirium tremens and something like that, seizures. Amphetamine withdrawal doesn't really fit here at all. Amphetamine is more of a toxicity type of question. When you take a lot of amphetamines, a lot of things can happen to you. Cocaine is also not relevant at all. So let's take a look at this page. There's a page in first aid under psychiatry where they go ahead and tell you about all the different drugs, right? Psychiatric emergencies. Well, psychiatric emergencies is one thing, but right here, psychoactive drug intoxication and withdrawal, right? This stuff. So we're looking at opioids, right? And remember, the left side is intoxication, right side is withdrawal. So withdrawal has these symptoms right here, right? Dilated pupils, piloerection, rhinorrhea, which they gave in our question. Nausea, of course, sure. You can even have diarrhea, right? So they call it all like flu-like symptoms, flu-like symptoms. And this you have to remember because obviously opioids are a major issue in medicine lately, and you have to know it inside out. And as far as the pupils thing is given, right? This question didn't really mention anything about pupils, but UWorld and first aid, sorry, not first aid, UWorld and step 1 are more likely to mention a pupil related thing to really try to get at you. Now remember that opioids are all about relaxing, right? I think I've written that here. It appears pale. Withdrawal patients will have extreme pain and flu-like symptoms, dilating their pupils for fight or flight. Yeah, right. Opioids take away your pain. They make you feel very, very relaxed, and you go to sleep. Now, when you close your eyes and it becomes really, really dark, your pupils will constrict, right? So that's what's happening right here. When you're relaxing and sleeping, you want to think of that as darkness, right, and no pain. So you fall asleep and your pupils constrict because it's dark. Whereas when you have pain and you're ready to fight somebody, your pupils dilate, right? That's part of the fight or flight response. Your pupils dilate to let in as much light as possible so you can get ready and take on whatever the danger is. That's something you really have to make sure you remember with opioids with regards to intoxication versus withdrawal. There's another one with cocaine as well. Now you see cocaine withdrawal isn't even given in first aid because there really isn't a major cocaine withdrawal thing. Cocaine is more of something that people use until they one day overdose and die, right? And it's not really necessarily overdosing, right? Typically we think of overdosing as you're supposed to take 1 pill a day. Maybe you took 10 pills to try to kill yourself. With cocaine, what happens is your receptors over time get more and more used to it, where every day you might be taking in the same amount of cocaine, but your body is getting more and more used to the cocaine, and one day you took the same amount of cocaine again, but it was highly sensitive to you were sensitive to that much cocaine now, and it's called an overdose at that point because what happens is, let's say, let me put numbers to it. So like, let's say every day you do 5 milligrams of cocaine, your body is like, wow, 5 milligrams of cocaine is really, doing the job. Eventually, you don't need 5 milligrams of cocaine to have the same effect. You could go down to 2.5 milligrams of cocaine. It will still have the same effect on the person. Keep cutting it down, and that would technically be the correct way of using cocaine, if anything like that. But if you keep using 5 milligrams and your body's becoming more and more sensitized, not tolerant. It's not that they become more tolerant to the effects of cocaine. They become more sensitized to the effects of cocaine. And eventually, one day, when you took that 5 milligrams of cocaine, your body saw it like 50 milligrams, and that's why they call it an overdosing, and you can die from cocaine, chronic cocaine abuse, right? But you can see with cocaine, the moment you take cocaine, right, you get pupillary dilation. Intoxication is about pupillary dilation, not pupillary constriction, because opioids are the ones that cause pupillary constriction because they take the pain away and they make you feel real relaxed. Whereas with cocaine, you want to think of this as someone who, it's a stimulant. So this is someone who took the cocaine and immediately became ready to fight somebody, right? A big time drug dealer. Just imagine anyone who's always doing cocaine, always ready to fight, pupillary dilation all the time because they're keeping an eye out to make sure no one catches them while doing the cocaine. And then of course the CO should remind you of coronary vasospasms. Alright, so very, very straightforward question. I can imagine people getting it wrong because opioid isn't here, but you have to keep in mind what opioid withdrawal looks like. And someone made the point, similar symptoms in fetal abstinence syndrome, right? So fetal abstinence syndrome is another scenario where a baby will be born, and the baby won't stop crying no matter how much you cradle it, no matter what you do for it, right? This baby is in pain. The baby might even have a runny nose, rhinorrhea. And all of this is happening because the mother must have been abusing opioids while she was pregnant, right? No doctor will ever prescribe opioids to a pregnant woman, But if she has opioids that she was abusing and she was doing it while she was pregnant, the baby also gets affected by that. And now that the baby is born, the baby also still needs opioids. And baby is still crying because baby feels pain from the lack of opioids, right? And that's what fetal abstinence syndrome is. Often tested. UWorld has a great question on that as well. Number 2 has this image over here, which, depending on how much experience you have with histological images, you either immediately know what you're looking at, or you're like, what the fuck is this? And then you start reading the question. If you're the second case scenario, where you just saw this picture, you have no idea what this really is, and then you start reading the question in hopes of having a better idea of what this picture is, that's really going to put you in a very intimidating situation. So at the very minimum, when you see something like this, you should be able to understand that we're looking at either bone or cartilage, because almost nothing really has a histological presentation like this, right? There's too many of the same kind of cells over here, and you're not seeing any actual, unique types of cells that you might be used to seeing, and you're not seeing blood, right? So this isn't a peripheral smear. There's a lot of things you're not seeing here. This isn't skin. You're not seeing all the different stratum, basale, and all of that. So you do want to make sure that you have good experience with images like this. And if you're preparing for NBME, what they often do is they take the same image and use it again. So you want to make sure you have a good idea of truly understanding what the images are about. So they give you this picture, and as soon as you see it, you should know this is some level of cartilage or bone. You start reading the question. 45-year-old man comes to the physician because of progressively worsening constant pain in his left thigh over the past 3 months. He is a long-distance runner. An x-ray of the femur shows thickening of the diaphysis and disruption of the cortex with focal areas of increased calcification. A glistening mass containing several cysts, right, so that's a pretty big deal. A glistening mass containing several cysts is surgically excised. A photomicrograph of tissue from the mass is shown. Which of the following is the most likely diagnosis? So when it comes to musculoskeletal stuff and bone cancers, one of the most important things is the age. That's like the giveaway for the answer choice, because a lot of these answer choices here are actually things that occur to kids. The other thing with all cancers in general is to make sure you understand, is it benign or is it malignant? Okay. Now for this guy, the answer was B. This is a chondrosarcoma. Right, mainly affects the axial skeleton rather than the appendicular skeleton, and it is malignant. Okay. There's many other answer choices on that page in musculoskeletal, and I know a lot of people have a tough time memorizing these correctly, right? So you don't need to know all of them. You definitely don't need to know all of them. But this list here, you really don't need to know all of them at all. From this page, you should make sure you know 2 of them, no matter what. And that's going to be the osteoblastoma and the osteoclastoma, which is a giant cell tumor. These 2 you definitely want to know, because you never want to get those wrong. The only other one that's significant as far as first aid is concerned is an osteochondroma. Right, now keep in mind, all of these over here are primary bone tumors, and as far as the danger level is concerned, it really comes down to just the age, right? So you can see how osteochondroma, there's memorization methods for all of these, and I've talked about it in the videos when I did this section. But osteochondroma, they tell you it's going to have a cartilaginous cap, and they show you an image of it. So I always put down, I always think of, imagine a younger man wearing a cap, right? So you remember that it's going to occur in someone under 25, like a college level student, and it's going to be an osteochondroma. Osteochondroma is not exactly that malignant, right? Compared to something that's labeled as a sarcoma, that's going to be much more problematic. So right here, when you come down to this area, you're seeing all your malignant tumors. Right over here, you have your benign tumors. So osteochondroma, osteoblastoma, and osteoclastoma, if anything, you want to make sure you know them. Their naming is also very important. This is a chondroma because this is more so cartilage related, right? Whereas this one here is related to osteoblasts. Remember, osteoblasts are the ones that make bone. And osteoclastoma is going to have too many osteoclasts, very aggressive, benign tumor. This one has a soap bubble appearance, right? Osteoclastoma. So you want to make sure that you get these things down pretty well, because it's a really big deal. And as far as the malignant tumors go, there's only 3 here, and you want to make sure you know all 3 perfectly. Right? So now osteosarcoma, this is the one that occurs right here. They tell you in males under age 20, right? Then you have your chondrosarcoma and Ewing sarcoma. Ewing occurs in even younger boys, right? Really younger boys. The only thing with osteosarcoma, though, is one of the step one's favorites because it's related to so many other conditions, right? It can be less common in elderly, but it can occur in older ages too, and it can be due to other risk factors such as predisposing risk factors such as Paget disease of the bone infarcts, radiation, familial retinoblastoma, which always has many other cancers to it, and Li-Fraumeni syndrome, which also has other cancers to it. Right? And then they give you the whole explanation of what it's going to look like, and there's an histological image over here that I put. A bunch of things happening here. But you do have to spend some time to make sure that you actually know these three, and then from the benign ones, those three that I mentioned, perfectly, right? Before you move on to the next topic, you should be able to reiterate what they look like, what they do, who they present in, and so on. So for this guy, this 45-year-old man, he has a chondrosarcoma, right? Chondrosarcoma, right? Chondrosarcoma. So now look at here. This is this one, chondrosarcoma, the one that's not the bigger deal of three. Right, that's kind of what NBME likes doing, right? Instead of asking a question on osteosarcoma or Ewing sarcoma, which are the bigger two of these three, they asked you about the least important one here, which is chondrosarcoma, right? It occurs in the medulla of the pelvis, proximal femur or humerus, tumor of malignant chondrocytes, right? And there's not much information about that in first aid at all, okay? So this is how a presentation of that would look like, right? And how would you get this? Well, to me, right, this is why I emphasized this image thing as such a big deal. To me, as soon as I saw this slide, I knew that they were talking about cartilage. And it was clear that at this age, this person, whatever they're talking about in this patient, something malignant has happened, right, with the focal areas of increased calcification, them having to do a surgical excision of it. So chondrosarcoma was the best answer choice to pick. The histology shown has pleomorphic cells, characteristic of malignant tumors. Malignant tumors include osteosarcoma, chondrosarcoma, and Ewing. Osteosarcoma occurs in the metaphysis of bones and the knee and has pleomorphic osteoblasts, which we don't see here, nor do they talk about the Codman triangle or any of the other predisposing conditions. Ewing sarcoma occurs in little kids, which automatically doesn't fit him. Okay, so we can't pick that. Now, as you can tell, there are G answer choices here, so that's what, 1, 2, 3, 4, 5, 6, 7 answer choices. So this is already pretty intimidating, but they do that because this could have had 10 answer choices. It wouldn't matter. You would pick the correct one based off of what you can deduce. The fact that this is malignant and this is cartilage. We're looking at cartilage here. Right? And these are all pleomorphic cells, which are pretty much a sign of cancer. Alright, so only 3 malignant ones to pick from, and it definitely wasn't osteosarcoma or Ewing sarcoma. So you pick chondrosarcoma and you move on. Alright, over here, number 3. Again, they give another histological image. This time, right, once again, when you look at the histological image, with questions like this, you're usually going to look at the question first because step 1, the interface doesn't look like this, right? So on step 1, you have your question and then you usually have the image under it and then the answer choices under it, kind of like it is in UWorld. So, but on NBME, you definitely want to go ahead and spend some time understanding, like 10 seconds. As soon as you see this picture, you should know you're looking at muscle, right? You're looking at muscle. Then you continue reading the question. 50-year-old man is found dead in bed at home. His family states that he had chest pain for the 3 weeks prior to his death. At autopsy, examination shows severe atherosclerosis of all 3 major coronary arteries, with myocardial softening and mottling involving the anterolateral wall of the left ventricle. And this this description that they're giving, right, myocardial softening and the mottling, these are all signs of an MI. A photomicrograph of a section from this area is shown. Which of the following is the most likely mechanism of death, right? How did he die? Now, the trick answer choice here was picking myocardial rupture, right? You would think he had an MI and he has some kind of myocardial rupture, but MIs are not really related to myocardial rupture, right? There's no necessarily a rupture at this point. It can occur later on, and this is all related to the topic of progression of an MI or evolution of an MI, right? So they described this stuff, right? The mottling, right? M-O-T-T-L-I-N-G. This mottling that occurs, and this infarcted wall is going to be real soft, right? This is the within the first 1 day, 24 hours, right? And he was found dead at home But we don't really have in this question how long ago he might have died. But we just know that he had chest pain for 3 weeks, and I guess he didn't really go see a doctor. Right, so we don't know how long ago he died, but the description they're giving, myocardial softening and mottling, makes it think he might have just died within the 24 hours, if anything within 1 to 3 days. Right, at which point you do still have some mottling, but now at this point this stuff starts to become more stiff, right? Because eventually it's going to become very solid and it's going to be too hard. It's not going to contract very well. The biggest issue with MI, like the number one biggest issue with MIs, are always the arrhythmia. Right? People can have an arrhythmia at any point after an MI, even if you were treating them correctly and things are going well. An arrhythmia can occur because of electrolyte imbalances, whether it be calcium or potassium, right? And those things are a very big deal. You will always ask questions about those things, right? Where is everything going to be? And because you lose the function of the ATP, the sodium potassium ATPase, remember it pump K in, right? You pump potassium in. Now you stop pumping potassium in, so you accumulate extracellular potassium, which can cause arrhythmias. In addition, you have intracellular accumulation of sodium and calcium. Sodium and calcium stays inside the cell. That pulls water, which causes edema, right? The heart becomes even weaker and more swollen, if anything. And all of that is a recipe for an arrhythmia. So that's a problematic thing. And that was answer choice A, and you would just pick that, right? Arrhythmias are also a very common cardiac reason of death. These other things are other issues that are related to myocardial evolution of myocardial infarctions, right? You can have a cardiogenic shock. You can have myocardial rupture much later on. Myocardial rupture occurs much later on, right? We see right here, you could have a pseudoaneurysm, you could have a true ventricular aneurysm, and all these things occur because the wall just isn't good anymore. And depending on how the patient takes care of them, post-MI, right? After their MI has been resolved and things have been taken care of and they go home, right? Within the 3 to 14 day period, if they're still not taking great care of themselves and maybe they're going through big stressors and whatnot, things can only get worse, right? You can have reperfusion injury. All of these are things that can occur, and some of these can even kill you, but arrhythmia would definitely be the one that would cause someone to die in bed at home. A paroxysmal nocturnal arrhythmia, right? Paroxysmal arrhythmias are actually a pretty big deal. That brings me to, it reminds me of another question where, let me see if I have that here. Yeah, arrhythmias, okay. All right, so this question up here, right here, was a UWorld question, which you can see talks about paroxysmal arrhythmias, right? This person, 64-year-old man, comes to the ED due to flank discomfort and red urine, history of hypertension and diabetes. 3 months ago, he had an ischemic stroke and has mild residual right-sided weakness because of the stroke. Creatinine is 0.9, lactate dehydrogenase is elevated, which means he has issues, right? LDH could be related to him having hemolysis or something. Urine microscopy shows many red blood cells. CT scan is performed, and an attached CT shows wedge-shaped infarcts in the right kidney. Which of the following is the most likely cause of this patient's symptoms? And the answer was an atrial fibrillation. He's having arrhythmias, right? Atrial fibrillation is the flank pain, hematuria, elevated LDH, and wedge-shaped right kidney lesion has renal infarction. The most common cause of renal infarction is systemic thromboembolism, either from the left atrium or ventricle. Atrial fibrillation, which can be paroxysmal, thereby going undiagnosed, may have caused this patient's recent stroke and is often a common cause of systemic thromboembolism. Nitin is saying that he thought that the MI occurred 3 weeks ago, right? Now, had the MI occurred 3 weeks ago, I mean, I can see why you might want to think of that, because they're saying he had chest pain. An MI is more than just chest pain. It could have been that he had an MI 3 weeks ago, but he never came in to get it checked. So his evolution of his MI, if he actually had it 3 weeks ago, let me see what page, 323, right? So the 3 weeks means 21 days. So he'd be somewhere down here. At which point, papillary muscle rupture is an answer choice, and getting what do you call it, an aneurysm is an answer choice, right? But at the end of the day, no matter what, you have to remember, even in the very, very end, right? I said 2 things. Let's assume, for example, let's say that it is true that he had an MI 3 weeks ago. Your heart after an MI is most susceptible to a ventricular arrhythmia in the first day, and then also, and most people tend to miss this, an arrhythmia in the end too, right? In the beginning, your heart couldn't contract because it got messed up, right? Now, your heart can't contract because it's too solid, right? Gray white scar, recanalized artery is just too solid. You could have arrhythmias here too, okay? And the main thing to catch in this question was the fact that your patient died at home in bed in his sleep. And the one thing that could have killed him paroxysmally would be an atrial fibrillation, right? It could be a ventricular fibrillation, an atrial fibrillation, anything like that. It could have been any kind of other arrhythmia whatsoever. But no matter when the MI occurred, he died of an arrhythmia, not of any of these other things. He didn't die from any of these other things. He definitely, most likely, not definitely, it is very unlikely that he could have died because of either D or E, okay? And as far as B and C are concerned, these are things he could have probably woken up for and called 911. But with an arrhythmia, he's just going to die without even having woken up. It's not like he's going to be able to really do much about it. So that's basically where the answer really comes from. An arrhythmia can occur anywhere throughout this entire thing, to be honest. It could even occur in these middle points over here. So just got to be careful and really consider like what's actually happening, right? There's a reason he died in bed at home overnight rather than dying any other way. So they're really not playing around with giving you images here. So now this time they gave you another image. This is going to make you think of microbiology, and you might either have a perfect idea of what you're looking at here or really not have any idea what you're looking at here, okay? So depending on where you are, even then, you should feel pretty comfortable because this is a big question. So they didn't just want you to pick an answer simply based off the image, right? It's very rare for NBME to have big questions like this. So let's take a look. 70-year-old woman is found to have persistent fever despite IV broad-spectrum antibiotic therapy 3 days after undergoing operative excision of the anterior pelvic organs for recurrent cervical carcinoma. All right, so she had recurrent cervical carcinoma. They gave her broad-spectrum antibiotic therapy, and now she has persistent fever. Right, that was a thick sentence. So I like to, this is how I read questions. Like, that was too much for me to catch, especially maybe because I'm done with, I was working 9 to 5 today. So I want to stop and make sure I know what I read before I keep reading. Her temperature is high, as they said. She has persistent fever. Physical exam shows the presence of a central venous catheter that was placed on the day of the operation. There is also a well-healing abdominal wound without erythema and with 2 drains in place. Blood cultures and cultures of the tip of the central catheter on a sheet blood agar plate grow the organism shown in the photograph. A gram stain of one of the colonies shows 4 micrometer elliptical purple budding organisms. Which of the following is the most likely causal organism? So they described budding, they described sheet blood agar, they described the fact that she's been on broad-spectrum antibiotic therapy, which really means that it's very unlikely she might be infected by a bacteria, right? And she had catheters, indwelling catheters. She's very, very old, so her immune system isn't exactly what it used to be. You look at all your answer choices. Now, she doesn't have a UTI, so we can knock this out. She doesn't have a UTI. The description of gram stain, they said is purple, which makes it gram positive, right? And E. coli is gram negative, so that also helps you knock that out. Cryptococcus neoformans would be extreme. Like, this is more so something related to the brain. We're usually thinking meningitis in immunocompromised patients, as I wrote here, so that's irrelevant. Sporothrix schenki is something you think of roses, and it causes skin manifestations, not what she's having. So that doesn't seem relevant. Now you have Staph aureus, which is a big boy, causes major issues, and it is gram positive. But Staph aureus does not bud. It's not something that buds. And this patient is on broad-spectrum antibiotic therapy, which means that it's very unlikely she's infected by some kind of bacteria. That leaves us Candida. You see Candida, she's pretty immunocompromised looking because she's very old. She's also slightly immunocompromised because of the broad-spectrum antibiotics, which really messes up her normal flora. And then all the catheters that she has placed, right? opens up her skin, which is your first defense. Candida is a part of the normal flora of skin. It could cause contamination of a central venous catheter. The question states that the organism is purple, budding, and that it did not respond to broad-spectrum antibiotics. Right? They didn't use fluconazole and amphotericin B. The yeast form of Candida is gram-positive. Lastly, they showed it plated on blood agar and there was no hemolysis, which eliminates Staph aureus. Right? Staph aureus is beta hemolytic, right? Because you know from the sketchy microimage that it causes beta hemolysis. And the first picture you learn about in sketchy micro is this Staph aureus, and this is the beta bulb right here. Right, so none of those things were really fitting. Like, I know it can be pretty intimidating on the real test, but you have to be calm and comfortable because you're gonna get 200 questions, so you can't really take any of these early questions roughly. Okay, again, another picture. Yeah, budding equals fungi. That was one definite thing, right? And then the fact that she's on broad spectrum antibiotics, so you couldn't really pick a bacteria as an answer choice. It was very unlikely to pick a bacteria as an answer choice. They did try to throw you off with gram staining. You don't really think of gram staining and Candida, but it is a thing. Page 155. So let's just take a look at it real quick. Candida, right, they tell you is dimorphic, forms pseudohyphae and budding yeast at 20 degrees Celsius, and germ tubes at 37 degrees Celsius. A bunch of other information here is given, but with all things, Candida is not completely discussed in first aid. So when we look at sketchy micro, they talk about it a lot more, right? Now, you can see how this ride is purple. That's supposed to remind you that it's a gram-positive in certain forms, right? It's also catalase positive, right? You can see there's a sleeping cat there. There's a lot to know. And sketchy micro is not just good for the visualization aspect of things, but also because they teach you a few of the extra things that are missing in first aid and a few other resources. So I've always added all of that into my first aid as well, and that's another great thing about it. So very important to make sure you're able to knock out answer choices based off of whatever information is possibly given. Now here, when you see this picture, you know that this is something GIT related because this is from the GIT somewhere in your gastrointestinal tract. And you know something happened here. Right? Something was looking really messed up right here. So a 66-year-old woman comes to the physician because of fever, chills, and left lower abdominal pain for 1 day. She has had increasingly severe constipation over the past 5 years. A barium study of the lower GIT shows 3 separate, poorly delimited regions of narrowing of the lumen of the distal sigmoid. Right? So 3 separate, poorly delimited regions of narrowing. A photograph of one of the lesions in the resected large intestine is shown. Right? So large intestine. So we're looking at the colon. Which of the following is the most likely diagnosis? Right? Now you look at all your answer choices: angiodysplasia, diverticulitis, granulomatous colitis, ischemic colitis, or ulcerative colitis. The clinical presentation is that of lower left quadrant abdominal pain, fever, and chills should alone make you think this is an inflammatory process, right? This is what they described in the question. Also, the question says there are 3 separate, poorly delimited regions of narrow lumen. As far as ulcerative colitis is concerned, answer choice E, there are no skip lesions, so you can definitely knock that out, right? They would be connected, not 3 separate areas. Angiodysplasia is a very cool answer choice, a very unique answer choice. Step 1 loves it too. This is one that would have all of these things. It would have hematochezia due to dilation of vessels of the right colon, right? Angio, right? Dilation of vessels of the right colon, and patients usually have either aortic stenosis or VWF disease, von Willebrand factor disease. These questions are really awesome because step 1, and that's why step 1 loves it. Angiodysplasia questions are going to start off with a patient who's presenting with symptoms of aortic stenosis, and they'll be like, oh, and I'm also vomiting blood for some reason. Boom. You pick angiodysplasia, you move on in life. Same thing with the other case scenario too. You're going to have a question that looks like it's a hematology question with von Willebrand factor disease, but then VWF or aortic stenosis, neither of these things will make you have hematochezia. All right, so When you see a combination of those things, you pick angiodysplasia, and we do not see that combination here, so you don't pick it. Now, this, coupled with the history of constipation, makes diverticulitis the best answer choice. The picture confused many people, but it is really just an unnecessary distractor. And this is something NBME is notorious for. In the next question, right, on the next NBME, they could use the same exact picture again to ask you a question about colon cancer. They could use the same picture again to ask you a question about some kind of infection. They can just do that because this picture was really unnecessary. You didn't need the picture. If you were trying to pick something off the picture, you'd be very much inclined to think this might be a granulomatous excuse me, a granulomatous issue, and maybe pick C. But what is granulomatous colitis? So granulomatous colitis is NBME lingo for, where is GIT? Alright, so if you look at Crohn versus UC, you know that Crohn disease, right, has non-caseating granulomas, and granulomatous colitis is just Crohn disease, okay? And Crohn disease has skip lesions and rectal sparing, right? So that skip lesions would be something that you would think, right? 3 separate, poorly delimited regions, skip lesions, right? But that's not what's happening. A lot of people, I'm sure, must have fallen for granulomatous colitis. 1, because you would think this is a granulomatous thing, and 2, you would think of the skip lesions, and this is 3 separate delimited regions. But that's not what's happening here. A person with Crohn disease does not simply have left lower abdominal pain, fever, chills, right, constipation. Crohn disease doesn't cause constipation. Crohn disease just sucks, right? It just sucks, and it causes many other issues, but not exactly constipation. If anything, it can cause diarrhea, right? So why is this person constipated? What is this concept of delimited regions? What does that mean? So you know that, where's the pencil? You know that in your colon, let's look at the colon, right? So let's say your colon is just a pipe, right? If some kind of outgrowth occurs in your colon, like a polyp, and you just keep getting more and more outgrowths, right? More and more outgrowths. So let's say that this is like a really, really long colon, and every little bit of space I'm leaving in between is like a good 5 inches right there, another 5 inches right here, and then you have a third growth. These are your 3 different regions of narrowing. You see how this is narrow? This is a narrow area, this is a narrow area, and this is a narrow area. 3 different places where a patient can have some kind of weird thing happening, which narrowed the lumen, right? And what is diverticulitis going to look like? So let's take a look at diverticulitis. Let me get rid of this image. Well, actually, I could just, there you go. So let's take a look at diverticulitis, page 416. Oh, 2 more pages. So narrowing, let's see, diverticulitis, right? Inflammation of the diverticula with wall thickening, classically causing lower left quadrant pain, fever, leukocytosis, treat with antibiotics. Complications can be abscess, fistula, obstruction, which can cause your constipation, and perforation. Right? You're seeing how there's like outpouching here, tiny outpouching, and it's always really problematic. Why does this occur? This outpouching, you have to remember, it occurs in areas where blood vessels perforate the colon, right? Blood vessels perforate the colon, and it occurs because of excess pressure, right? They call it intraluminal pressure, right? Increased intraluminal pressure. The pressure just causes it to just plop out, right? And that's what you're seeing in this area right here. Now, when this starts occurring, with decreased blood flow, you start getting the narrowing. The narrowing starts occurring because blood flow to these areas are not going to be that good, right? And they did describe in this question that this patient had left lower abdominal pain. And you can see how this is the left lower area right here, right? This is diverticulitis. Many diverticulas, right? This is the left lower area, okay, where you're going to have a lot of pressure. I always think of it as a lot of pressure because from here on is where you're going to start pooping. So it's taking these people a lot of pressure to actually start defecating, right? And when they pressure harder to actually poop correctly, this area is where everything is sitting to finally be evacuated. You end up pushing out blood vessels in your colon, right? And you get all these 3 different areas of delineation or delimited narrowing, because eventually, since you plop out these areas, it does thin up. This is going to start closing in because it's just not getting the right amount of blood supply that it needed, or that it needs now because of the diverticulars that have formed, right? So the other answer choices just wouldn't fit. Remember, constipation was the giveaway here. Without the constipation, it would be a little harder to pick a correct answer choice here. Again, an image. So now here you might not know where you're looking, but you do understand that you do actually see cells. And even though you might not know where exactly you are or what exactly you're looking at, you definitely know what you're not looking at, right? And that's always valuable information too. There's a lot of things you're not looking at. For example, you know you're not looking at cartilage here, right? So that's definitely helpful information. You read the question, a 51-year-old woman comes to the physician because of a 6-month history of burning abdominal pain that occurs 1 to 2 hours after eating. She sweats profusely and has lightheadedness when she stands. Her blood pressure is pretty low while standing. Physical exam shows epigastric tenderness. CT scan of the abdomen shows a 2-centimeter mass on the proximal duodenum. Right, so a duodenal mass. Gastrin, released by the tumor cells, stimulates which of the following labeled cells in the photomicrograph to release hydrogen ions? So again, now that you've read the question, you know that the entire scenario they gave you was just bullshit. You didn't really need it. This is just asking you what cell does gastrin work on. Now, of course, they gave you a really, unorthodox image, one that you might not be very well used to, but you know that gastrin affects parietal cells. So you need to find your parietal cells. Okay, now how are you going to do that? So in this image, parietal cells was actually B. Right? B is your parietal cell. These cells that you're seeing here, these are all parietal cells. They're the ones that are going to release hydrogen ions. This is another image I found online where they actually kind of helped you see it. You can see the parietal cells are the pink cells with a prominent nucleus, an actual nucleus that you can catch. Right? Those are all your parietal cells. The other things, your dark cells at the bottom here, these are your zymogenic cells, which are going to release digestive enzymes. The tinier cells are your neck cells that release mucus, not really something significant that you need to know about much. Even the pit zone cells, also not that important, but the mucus releasing cells are actually very tiny and irrelevant. All right? Tiny and irrelevant, but these bigger cells that you're seeing here that are very obviously cells with nucleus and whatnot, those are the guys that are your parietal cells. How you would know this is really just based off of experience. If you've never really looked at GIT images, you can't really answer something like this that easily. Now, in my book, when I was studying GIT, I realized that histology was definitely a pretty big deal. Right? They care about this histology of stuff because first aid did spend some time putting this in. Right? This wasn't there in more previous first aids. So even before they started doing it, I had good images that I had found online, studied, right, understood the transition zones of, and gone through the entire GIT in a good histological fashion in case it was ever given, right? It's obviously very common to get GIT histological images where just by looking at the histology, you should know exactly where you are. For example, in this image, because you see submucosal Brunner's glands, you know you're in the duodenum. And then you can start picking out other things, right? Here, you can see your plicae circularis, no submucosal glands, so you're not in the duodenum anymore, right? And this is the jejunum. The ileum is the one that has your Peyer's patches, right? And so on and so on. You want to really make sure you know all the different cells, cell types, how the different parts all look like, right? Your different plexuses, what they do. So you want to spend some time and even have cells, right? So you can see your parietal cell. Very prominent, simple pink cell with a very obvious, like you can't miss it, type of nucleus. This is how your parietal cell looks, and you want to make sure you remember that. Obviously, a very important cell. Right? And knowing that will help you because if they're not asking for parietal cells, then you will make sure you don't pick B. And then in the next NBME, they could use the same picture again and ask you about one of the other guys, right? So like E would be something that releases mucus. C would also be something that releases mucus. These are pretty irrelevant types of cells over here, right? In fact, in this image, I don't really think anything else is really that relevant or important per se. All right, so that was number 8. Number 9 also is an image. Right? This was a really interesting question. Oh wow, it looks like NBME 21 was full of images. It's like every picture, yeah, every question is an image. Holy shit! All right. Anyway, number 5, a 65-year-old. Oh, this is number 7. I mean. Number 7, a 65-year-old man dies in a motor vehicle collision. Okay. Photograph of a lung as seen at autopsy is shown. Which of the following is the most likely diagnosis? So you got your autopsy done, and this is what you're looking at. Okay. So then you look at all your answer choices. Is this an abscess? Is it a hamartoma? Or is this an infarct? Could it have been a malignant lymphoma? You might not even know how that looks like. Is this a patient who had gone through mesothelioma? Or could this just have been someone with squamous cell carcinoma? And if you remember your lung cancers very well, then you would immediately pick F and just move on, because this is squamous cell carcinoma. Now, up here are your other things, right? So A, B, C, and E from left to right. So A here is showing you an abscess, right? You can see it's an abscess. It has nothing to do with the external parts. It's in one little area, right? Any of these things could be another image in another NBME question, right? You could find images like this all over the internet. And these are very good images because they do the job. An abscess would always look something like this. And it can also occur at the bottom. A hamartoma will look like this. Remember, hamartomas are usually your normal tissue, just too much of it. So it's just a lung tissue, but just too much of it, right? So it's extra tissue, not an explosion or something. Of course, infarcts can be red or white, and this is a red infarct here, right? Actual bleeding. Then you can easily pick an infarct and move on in life. Malignant lymphoma, let me see, I think it's this one right here. What is this? I probably couldn't find the picture for malignant lymphoma. But this picture, this is a very important one you have to remember. Look at the lung. It's encased. It's encased in something. That's from mesothelioma. Right? Mesothelioma is known for having an encasing around the lung, right? And it's going to have a, well, you don't necessarily need to have a patient history and whatnot. Step 1 will give you a little more information. You will, so NBME could just toss this image at you and tell you that the patient died and then ask you what this is. And you have to be able to pick the fact that this is mesothelioma. And then this one down here is another image, right, showing you another squamous cell carcinoma issue. And you can see how this kind of looks like the same abscess stuff, but it's not that similar, right? There's a lot of other messed up tissue around it. And you can see with the abscess, nothing around the area is messed up. It's only the abscess itself that's there, right? Like an explosion occurred, a little mine exploded. But the rest of the land is okay. Right here, the rest of the land is also affected, if you think of it in terms of land. And same kind of effect here. An explosion occurred and the rest of the land is also affected. So it's not just an abscess. This is squamous cell carcinoma. Right? Squamous cell is centrally located and has cavitation, which you can see in this picture, right? Similar to this other picture, which I put right here. Macroscopically, squamous cell carcinoma tends to be off-white in color, arising from and extending into a bronchus. Right, very important to know that. So we're actually doing respiratory in our full mastery playlist, right? We're done with what do we call it? Actually, we're done with it, right? We're done with, no, we're not done with pathology. We're not done with pathology yet. We're in respiratory pathology. So if you look at your lung cancers, small cell is very important to remember because of all the hormones it can release, and usually patients will present due to symptoms of those excess hormones. And then you pick small cell carcinoma and you move on. There's a lot of immunology involved too. Then your non-small cell cancers, you have your squamous cell, which has a lot of C's to it, right? Squamous cell carcinoma, central, cigarettes, cavitation, just like abscess, and hypercalcemia because of the PTH-related peptide, right? So very, very easy question actually, right? Very easy question. But again, if you don't have that experience, then it becomes a very difficult question, and you might be inclined to pick between either abscess, infarct, even malignant lymphoma. You know, how would that even look like on the lung? So now here, again, you have an image, and you should be able to see that they took some kind of bug, and you can see the bug here, and you should be able to identify what the bug is too. It's a very good picture of it. That's Giardia. That's like blatantly Giardia. There's no way. Yeah, questions get repeated very often. I haven't looked at NBME 16, but they repeat questions pretty often. They also repeat images. And this image is very obviously Giardia. 22-year-old man comes to the physician because of a 2-month history of foul-smelling, watery diarrhea with significant flatulence. Giveaway for Giardia. He also has a 10-pound weight loss during this period, recently returned from a trip in rural Indonesia, where he did not always have access to clean water. Again, another giveaway for Giardia. He looks thin. Physical exam shows a soft, mildly distended abdomen with active bowel sounds because he has flatulence. A photomicrograph of stool specimen is given, which is your answer here. Most appropriate pharmacotherapy has which of the following mechanisms of action, right? So they asked you a third degree question. Now, first degree question would be to ask you, what is this infection? Second degree would be to ask you, what is the treatment for it? A third degree question is asking you the mechanism of the treatment of the infection, right? So if you don't even know what the infection is, and then you don't know what the treatment is, you definitely can't figure out the mechanism of the treatment. But Giardia is treated with metronidazole. And you have to remember this for yourself in any way you can. Page 159. But sketchy micro is what I've mastered it with, right? So when I look at Giardia, I always think of this image right here. And then you can always remember, these are what Giardias look like. You find it in dirty water, right? So you have the feces here. Dirty water, people are drinking it, right? And they're drinking it, and they're all going to get really, this guy's closing his nose because they're going to get really gassy. So a lot of flatulence. And the metro in the back over here is to remind you of metronidazole. Now, how does metronidazole work is a whole different thing. Formation of destructive free radicals is how metronidazole works. Drug of choice for Giardia is metronidazole. Mechanism of action is the formation of toxic free radical metabolites in the bacterial cell wall that damages DNA, making it bactericidal, and anti-protozoal. So it also does the protozoal cell wall, or protozoal wall, I guess. Metro treats GET-GAP, right? GET-GAP, which is Giardia, amoeba, trichomonas, Gardnerella, anaerobes, and H. pylori. Anaerobes that are below the diaphragm, right? As opposed to clindamycin. And H. pylori, you could use metronidazole as an alternative to amoxicillin in someone with penicillin allergy. Adverse effects of metronidazole are just disulfiram-like reaction, HA, and metallic taste. All right, so very straightforward medication, very important medication. You definitely want to make sure you know this stuff very well. 11, you see this and you should be able to figure out the fact that we're looking at female organs here, and these are your ovaries, so something must be wrong with this patient in their GU system. 25-year-old newly gravid woman comes to the physician because she and her husband have not been able to conceive a child for 3 years. Yeah, trichomonas. So they haven't been able to conceive a child in 3 years. So at this point, right, as a OB/GYN doctor, you should be able to think of the fact that what are all the things that can cause a woman to not be able to conceive, right? And one of them, of course, is also the fact that the man might have a problem and his sperm might not be good enough. But since they've given you female organs here, there's definitely something wrong with the female. Previous evaluation of the husband showed no abnormalities in spermatogenesis, so the man is good to go here. Menarche was at age 13. Menses occur at irregular 60 to 90 day intervals. She's 5 feet 2 and weighs 68 kilograms, 150 pounds. Right, so for a 5 feet 2 woman, 150 pounds is pretty heavy. And they tell you that by giving you the fact that her BMI is 28. Physical exam shows hirsutism, which is a giveaway for the diagnosis. Ultrasonography of the ovaries shows numerous cysts beneath the capsule. A photograph of the uterus and the ovaries from a woman with a similar condition is shown. The patient is at greatest risk for developing which of the following conditions? Hirsutism, difficulty conceiving, BMI of 28. This is all a giveaway for PCOS, polycystic ovarian syndrome. And what is she at the greatest risk of having? So they gave you a bunch of answer choices. But with these people, you know that the treatment for them, for these women, is to put them on oral contraceptives to regulate their menses, regulate their irregular menses, right? Which also they gave you here. Irregular menses occurring every 2 to 3 months. And all of that irregular hormones can actually end up causing endometrial hyperplasia. That was what she's at risk of. None of these other things. PCOS is a very big topic, but also a very easy topic. It's just a bunch of stuff that's happening here that you can easily understand if you just spend one good session of studying it. Let me see. Choriocarcinoma, no. Right here, PCOS. Okay. So, also known as Stein-Leventhal syndrome, which no one ever does. There's going to be hyperinsulinemia or insulin resistance that then alters hypothalamic hormonal feedback, right? So you're going to have high LH, very high LH, not enough FSH. You're also going to have high androgens, which is why the patient ends up having hirsutism. Decreased rate of follicular maturation, so the follicles don't mature, they end up becoming cysts, and then you get anovulation, and this leads to decreased fertility, right? Enlarged bilateral cystic ovaries if you're not treating it. Presents with amenorrhea, oligomenorrhea, hirsutism, acne, decreased fertility. Associated with obesity, acanthosis nigricans, which is a sign of insulin resistance. Increased risk of endometrial cancer, secondary to unopposed estrogen from repeated and ovulatory cycles, right? This is why the first thing you want to do, of course, after telling them to lose weight, is to put them on oral contraceptives. This is going to prevent endometrial hyperplasia, right, which is what our question is directly about. And PCOS, because it's involving so many different mechanisms and so many different hormones and so many different things, and the fact that it's a very common thing, you can get all kinds of questions on it, right? And here at the bottom, I've got notes from AMBOSS regarding the progestin challenge test and hormones that you're supposed to notice. Here is the UWorld note about clomiphene, another medication you can use for patients who are looking to get pregnant, even though they have PCOS. It's not that they can't get pregnant. They have to regulate everything and take treatment for it, right? So clomiphene is listed here, and I discussed it. You could also put them on finasteride, a medication that is not exactly that good for men because it can lead to decreased libido, and not decreased libido, but more so mess up the apparatus. You might not be able to have erections, right? But finasteride in men is often used in low doses for male pattern balding and in higher doses for BPH treatment, right? But in women, you don't have that issue of erections, right? So you can give women finasteride to counter the hirsutism they're having, right? That's a big issue there. You can also put them on spironolactone, which again is also something that would be problematic to give to a man, but you can give it to a female just fine, right? And of course, flutamide also for the hirsutism. All of these are spironolactone, finasteride, and flutamide are all things that you can give for hirsutism. That's a very big topic. You want to make sure you grab this very, very well. This one might actually intimidate you too, because of course here you will recognize exactly what you're looking at. It's a cross-section of something CNS related, your spinal cord, but you might not have perfect memory of what each part of these things do. And if your neurology is weak, you're not yet ready for step one, right? You might not entirely be ready for an NBME either. You want to make sure your neurology is perfectly up to par, where you know everything about the brain and the spinal cord and the whole CNS and PNS very, very, very well. And in my full mastery playlist, I did a really good job with that too. So I've gotten a couple people who asked, what is the full mastery playlist? So it is an actual playlist on my YouTube channel, right? It's called the full mastery playlist. It goes through every chapter one by one, right? I've minimized it to the best of my capabilities, where I don't talk about anything unnecessary, and I try to keep going and going and going, and help you master topics while also integrating UWorld questions, AMBOSS questions, extra images and whatnot, right? We've got everything. This is only up to MSK right now, but it keeps loading, right? There's neurology. Neurology is a really big chapter, but you can see like eventually some of these videos are under an hour each, right? In the beginning, some of the videos are much bigger. And by the time I'm done with this, right now I'm only up to respiratory pathology, number 13. By the time I'm done with this playlist, it should be about 200 videos, amassing to about 240 hours, right? Which is perfect because it's a free playlist of mastering everything, and you don't really need to pay for Kaplan or anything like that anymore. So that works out pretty nicely. But here you see this image, and then you read the question. So you know this is CNS related. This is your spinal cord. Photograph is shown of a myelin-stained cross-section of a spinal cord obtained at autopsy from a 50-year-old woman. She sustained a spinal cord injury in a motor vehicle collision 15 years prior to her death. Which of the following symptoms would most likely have been present in this patient as a result of the damage indicated in the photograph, right? So now you're thinking, where's the damage here, right? Is it this thing here, or something happened here? Like, where's the damage here? So you look at all your answer choices. Now, the correct answer here was E, loss of sensation to vibration over both feet. But how would you figure out where is the damage here? Well, remember, they told you that this is a myelin-stained cross-section, right? Myelin-stained cross-section. This was a very easy question. They didn't want to pick on anything intense. The only place that's not staining with myelin is right here. Right, this is your fasciculus gracilis, this area and this area. Right, your left side and your right side. The fasciculus gracilis is not staining. Everything else is fine. Everything else is staining. This stain, your cuneatus is staining, right? Everything else is staining just fine. Everywhere else that you have myelin is staining. It was not this thing. Whatever happened here is just an error in making the slide, right? It's not that it's showing you damage. So let's take a look at page 550. A very straightforward question. They didn't even really pick on spinal thalamic versus any other section. So this is how it normally looks. You see how everything is stained? Right? This place is white in that picture. And that is your, obviously your dorsal column, ascending, sensory, and specifically they were looking at the gracilis, which is for your legs. Cuneatus is for your upper body and arms, right? The upper parts here are descending tracts. These are your motor tracts, corticospinal. Right, motor tracts, the upper parts here. So it's really easy to remember because right after arms and legs, you have the ability to move arms and legs. And then the last thing here is spinal thalamic. Right, so very easy to remember that. You have your sensing arms and legs, moving arms and legs, and then spinal thalamic, which is just for heat. Just for heat. Yeah, graceful legs, right? Very common thing. That's a very common way of remembering it. Gracilis for graceful legs. And of course you also want to think of a ballet dancer, right? When a ballet dancer does their spin, they close their legs in and open their arms out so they can turn. When you close your legs in, you want to think of this. The legs are the inner ones, which is your gracilis here. Cuneatus are the ones that are outside. That's for your hands. Very straightforward. Like there's nothing crazy about that. It can get much more confusing once they, of course, start asking you about other things relevant to those, like where they decussate. Right, so in my videos, I've also made that very straightforward, right? This is not so hard at all. Your spinal thalamic tract, which is one that senses heat, right, comes and decussates immediately at the ventral white commissure, and then ascends contralaterally. Ascends using what? It uses the spinal lemniscus. Where is the spinal lemniscus? It's right after the gracilis stuff, right here. Right, same place where your corticospinal tract is here, but the spinal lemniscus we're looking at is at a different thing, right? That's your medulla. Right, we're looking at the medulla. In your medulla is the spinal lemniscus. This image up here is not the medulla. This is below, even further down, is your spinal cord, which is this thing. So it decussates using the spinal lemniscus, which is something that you can have in answer choices. Goes to your VPL, right? VPL, ventral posterior lateral nucleus. VPM was makeup on your face. VPL is for everything, well, spinal thalamic really, but sensory stuff. VPL is also the other sensory stuff, which is your dorsal column stuff, right? The below tracts or dorsal column. And you can see how in the spinal tract, the legs use your medial gracilis, the arms use your lateral cuneatus, ascend, and then decussate at the medulla using your nucleus cuneatus or nucleus gracilis, no big deal there, and then just go up. Right? Nothing crazy there either. The other one, your descending tract, which is your corticospinal, this one uses something special. So you have to remember, where is it? Key parts, I wrote it right here. Yeah, the pyramids and the internal capsule, right? You get internal capsule strokes pretty often in this pyramidal tract. So internal capsule is a pretty big deal, right? Don't forget the internal capsule stuff. Very important to remember that. Right, using your bulbar stuff and internal capsule and muscle movement. Usually when you have internal capsule strokes in a patient, they're going to present with simply nothing else but motor deficit. Sensory stuff is going to be just fine, but they're going to have motor deficit. That is a sign that someone had an internal capsule stroke, right? Pure motor stroke. I think this is one of those questions about that too. Right? A pure motor stroke. So again, you want to make sure you spend good time really getting a hand of different cross sections, whether it be the medulla or your spinal cord, what it looks like, and then of course later on things get even more complicated when they want to talk about the pyramids and your where is it, the different tract lesions, right, with your what were they called, with the tongue deviating in, oh, right here, ASA, pica and ica, right? These things, right? These things are also pretty complicated. But you want to make sure you get this stuff down with whatever mnemonics you can, right? Don't pick a horse that can't eat, because hoarseness and dysphagia is a giveaway for pica, and ica is pooped, right? Facial droop, pooped. Very easy once you just use those mnemonics, but at the end of the day, before step 1, you want to make sure you're using more than just mnemonics to master stuff. And this didn't even require that much. It was just a lack of the gracilis. Very easy question. Again, an image, they show you a pretty old person's hand with some kind of lesions on it, right? And then they go on to tell you a 62-year-old man who is a farmer. Now remember, being a farmer is related to many things on step 1. But in real life, being a farmer is one thing for sure: sunlight exposure. You're out in the sun. Comes to the physician because of an 8-year history of lesions indicated by the arrows shown in the photograph. Although there is no itching, he occasionally picks at the lesions, which causes some bleeding. Physical exam shows numerous similar rough plaques on the scalp, face, ears, and forearms, all of which are areas that are prone to sunlight. Which of the following is the most likely diagnosis? And this is actinic keratosis. That's all it was. There's really nothing else to pick. Some people wanted to pick basal cell carcinoma because of the bleeding, but it wasn't natural bleeding. Anything you pick on will eventually bleed, so it was just normal for him to be bleeding in those areas. It wasn't hand dermatitis. Dermatitis is almost like an allergic reaction, if anything, but dermatitis is going to be in result to something causing dermatitis. And all they told you here was that he's in the sun and that he's a farmer. Seborrheic keratosis is a whole different thing. Psoriasis, you should know exactly what it looks like. It doesn't cause lesions like this. Psoriasis is big lesions where your skin is all kind of like twisted and, molded up and whatnot. It's just going to be messed up. It can be anywhere on your body. Usually it looks nice and pink, but the skin is all messed up. You want to see many pictures of psoriasis. Very important to know how that looks like. This definitely wasn't squamous cell carcinoma, not tinea corporis. Tinea corporis would be corpus on the body, so your corpus. But this was not a tinea thing at all, and not verruca vulgaris either. Students got confused from the bleeding in the question and felt it might be psoriasis, but the lesions are not psoriatic at all. This does not look like psoriasis. The farmer picks carrots, right? Farmer for sun exposure and squamous cell carcinoma, carrots for keratosis. And page 526, so let's take a look at what's happening with that. Right, miscellaneous skin lesions, right, and you have your actinic keratosis. Seborrheic keratosis is benign. Actinic has action because it can lead to squamous cell carcinoma, right? But seborrheic keratosis, I think, is discussed in an earlier part of this section. Right here, seborrheic keratosis. Flat, greasy, pigmented squamous epithelial proliferation of immature keratinocytes, and it looks like image K. Like this, right? So it's really dark, and there is a little horn type of thing sticking out here too, right? It looks stuck on, horn cyst, but that's not what our patient had. Our patient had actinic keratosis, which can occur like this too. Our patient had it on his ears, on his scalp. He had it because of sunlight exposure, right? And risk of squamous cell carcinoma is proportional to the degree of dysplasia, right? Obviously. The newer thing with squamous cell carcinoma and basal cell is this thing, right? This is something that wasn't there in many of the previous first aids. They put this in 2019 to remind you that the basal affects your upper lip and areas above, whereas squamous affects the lower lip and areas below. Okay, so basal cell carcinoma is the most common skin cancer and is found in sun-exposed areas of the body, locally invasive but rarely metastasizes. You're going to have waxy, pearly nodules like this above the lips. You see how it's below his eyes? So very important to remember that. Good stuff. Nothing crazy here. Here they give you a histological peripheral smear, right? You can see that you're seeing a bunch of red blood cells that are all nice and round, so there's nothing crazy wrong with them. And you're seeing a couple neutrophils, and they have a couple lobes to them, but this one here looks like a band cell, right? This one has not exactly lobulated correctly. It's a band cell. It looks like an immature neutrophil. So a 68-year-old woman has had a fever and shortness of breath for the past week. X-rays of the chest show a right lower lobe infiltrate. Leukocyte count is 38,000. Peripheral blood smear is shown. Which of the following best describes her peripheral blood smear? So, now, could she have some kind of cancer or is she just reacting to some kind of infection? Now you know she has an infection. They told you that, right? Because X-ray of the chest shows right lower lobe infiltrate. So she has some kind of infection. Leukocyte count at 38,000. Again, let me just check real quick before I say something. Normal leukocyte count. Because it's not something I look at every day, but you should know what the normal leukocyte count is. Why is my search not just Google? Wow. I hate when something updates and Yahoo becomes your, or Bing becomes your main search. Normal leukocyte count 4,000 to 11,000, right? This patient's is elevated, so that's what I kind of wanted to say, right? Hers is higher than normal, and that's pretty much giving away the fact that she's fighting infection, right? She's fighting infection. The other thing I said, band cell, right? These neutrophils don't look that bad. They're neutrophils. They're normal neutrophils, but this one is definitely a band cell. She's reacting. This is reactive granulocytosis. This is not a patient with leukemia. They didn't give you anything for her to have leukemia. They didn't say she's weak, she's losing weight, anything. Nothing at all. No reason for you to pick leukemia. If you did pick leukemia, you would pick aged men leukemia, AML, right? Remember, AML is aged men leukemia. ALL is adolescent little leukemics, occurs in kids, right? This is not AML. Remember, aged men walk with a rod, a cane. Aged men leukemia or acute myeloid leukemia would have hour rods, and we don't see any hour rods in this picture either. So we can definitely knock out A and B. And since it's not either A or B, it's not going to be C either, chronic lymphocytic leukemia. So now you were just between D or E, reactive granulocytosis or reactive lymphocytosis. And these are granulocytes, neutrophils. Neutrophils, right? So you go ahead and reactive granulocytosis. Acute lymphoid leukemia, look at these monster lymphocytes in the first image above, right? This is it right here, right? Acute lymphoid leukemia. This is something that occurs in adolescents, which is why I named it adolescent little leukemics. And I have that in my first aid too. Let me see, just make sure. 4, 5, 6. The page numbers have shifted a little after I added more pages in. Right here. So these are your leukemias, okay, right? So ALL occurs in kids, adolescent little leukemics. You're going to see many lymphoblasts, right? Lymphoblasts, and that's what we're seeing right here. This is answer choice A. Answer choice B, acute myeloid leukemia, is aged men leukemia. Watch out for their faggot cells. And a faggot is a bundle of sticks, right? So a bundle of sticks, we're thinking of hour rods, right? That's what that is about. And we're seeing, not this one up here, that's the smudge cells are a different thing, but this one right here, you see your rods? Those are your hour rods, right? This is aged men leukemia. The sticks are crystals made of myeloperoxidase. Look at the set of images below. Now, chronic lymphocytic leukemia, answer choice C, it's chronic. It's the one that has smudge cells. The smudge cells are the ones that you're seeing in this picture, right? Smudge cells. They're smudged. They're squeezed and rubbed, right? Smudge cells. None of those things were given to us. We have a normal peripheral smear with band cell, which is a sign of the fact that this patient is making neutrophils to fight infection. There's one more difference you have to remember, because that is tested. It's this, leukocyte alkaline phosphatase. In CML, your leukocyte alkaline phosphatase will be low. LAP is only high when you're actually trying to fight infection, right? But here it's low. It's low because you're not fighting infection. This is a result of low activity in malignant neutrophils, right? Chronic myelogenous leukemia, you have neutrophils. You can see neutrophils. Of course, you can see other cells as well. You can see neutrophils, maturing granulocytes. But those neutrophils are cancerous. So your leukocyte alkaline phosphatase is low. When you're having reactive neutrophils, you're making neutrophils to fight an infection, LAP will be elevated. And LAP is a very good test to check whether someone has infection, or is it just is it because of reaction to an infection, or is it just leukemia? If it's leukemia, LAP will be low. Low action, right? Low action. You're not taking action, you have leukemia. Right? So very important to remember that difference. And that's what this question was about. Here they gave you this picture in the middle. I put this here for reference to figure out what everything is. but you should know what all of these things are because that's what first aid teaches you. So they give you this picture. It's labeled with all these answer choices. This is obviously a pretty normal looking brain. 43-year-old woman dies after a 10-year illness characterized by irregular jerking movements of the extremities and a disjointed gait. She had profound dementia during the last 2 years of her life. Her father had a similar disorder and died at age 65. Right, so you can see there's some level of anticipation happening. Right, this patient died at 65. This patient must have gotten it even younger because she had it for 10 years and then she died at 43. So there's some level of anticipation there. An autopsy examination of this patient's brain is most likely to show severe atrophy of which of the following labels structured in the MRI of the normal brain here. Right, A, B, C, D, E. Now, this patient has Huntington's disease, a very common neurodegenerative disease that is autosomal dominant, which is why her father had it and now she has it. And it does have anticipation, which is why she got it at a younger age than the father had it. Remember, hunt for an animal and then put it in a cage, CAG, right? CAG is the repeat, the triplet repeat in Huntington disease. Huntington gene is found on chromosome 4, which the word hunt has 4 letters, or you could think of the number 4 here. Huntington causes histone deacetylation, which then silences genes that are necessary for neuronal survival. Remember, acetylation activates genes. When you deacetylate it, it's kind of equivalent to methylating it, and you mute the gene, right? CAG is the trinucleotide repeat, and caudate loses acetylcholine and GABA. That's kind of also what CAG can stand for. That trinucleotide repeat reminds you of CAG, caudate, acetylcholine, and GABA. So all you needed to do was find where here is your caudate. Okay, and the answer was C. The C is your caudate. This caudate would be degenerated in the patient's MRI, the patient who has Huntington disease. All right, very important neurodegenerative disease. You want to make sure you know this inside out because clearly there's many ways to ask questions on it. Right, Huntington disease. 4 letters: Hunt, CAG, caudate, acetylcholine, GABA. And then the thing I was talking about is this, right? Deacetylation. Mutant Huntington stops histone acetyltransferase. So your relaxed chromatin will now become victim of histone deacetylase, which causes chromatin to become condensed. Now that it's condensed, you have decreased transcription of neurotrophic factors that are good for your brain. You stop making them, and then you have impaired neuronal survival. And this is most actively happening in the caudate of the brain. So you lose the caudate in Huntington disease. Right? Very important to get that down. So that's all this question was about. If you knew it, you knew it. If you didn't, you didn't. You got to know everything else here too. And this picture kind of helps you get that stuff down. Then we have a lung cancer question, right? So they gave, not exactly a lung cancer question. This is a heart question. Very, very interesting. They used these angles that Amboss kind of uses. Amboss uses this angle over here a lot to teach you what's happening. But this is a very interesting, straightforward cardiac question. 43-year-old man comes to the physician for a follow-up exam. 10 years ago, he underwent cardiac valve replacement. Chest x-rays are shown. Based on these findings, where was the valve most likely replaced? So it's just based off of the direction. If it's looking like this, right, that means that blood must be flowing through it. It's right here. You can see it. It's right there. Okay. You can obviously see it much better in the lateral view. But even from the lateral view, you could tell blood must be flowing in that direction. So that means it must be flowing in that direction. And this is obviously your aortic valve. It can't be anything else. Right. That's it. If it was the mitral valve, it would probably be something like this over here. Right. And remember, blood from the mitral valve goes from your left atrium to the left ventricle. So even the rest of the valve would kind of be facing like this. Okay. And that's really all there was to it. It was a very simple and straightforward question, but I can see how someone might get intimidated because you've probably never seen a question like this before. And NBME does that. Step 1 does that too. You can see questions on your step 1 that you've probably never seen before. And so be ready for that. I found this image online somewhere where they kind of labeled out the other valves and how they would look like. Okay. So very nice to be able to see where you would see them. Your aortic, pulmonary, tricuspid, right? How they all look like. But this one was very evident. This is definitely aortic. It's going in that direction. Okay, so nothing much more to talk about there. Here, you know what you're looking at is a CT of your abdomen. So, 37-year-old man is brought to the emergency department 45 minutes after sustaining injuries in a motor vehicle collision. Severe, sharp right-sided chest pain. Respirations are 30 per minute and labored. Physical exam shows numerous areas of trauma to the right side of the head and thorax. So while you're reading these things, you want to imagine this patient in front of you acting like this, right? Respirations of 30 per minute and labored, right? Normal respiratory rate, when you're not really in crazy pain, you just breathe about 1 breath per 2 seconds, right? So his isn't so far off, but it's labored, okay? Physical exam shows numerous areas of trauma, right? He's gotten all beat up, head and thorax. Breath sounds are decreased on the right. Right, so this motor vehicle collision definitely caused him major injury. Breath sounds are decreased on the right, which means that there's not much happening in that right lung. And we can kind of, in this image, we can kind of see it. Then they go on to tell you that there's hyperresonance in the right thorax. Right? And hyperresonance means that the lung has collapsed and there's all this excess air that's resonating sound. Okay. Physical exam shows decreased tactile deformities and adventitious sounds are absent. X-ray confirms multiple rib fractures. A CT scan of the chest is shown. The most likely afferent pathway of this patient's chest pain is carried in which of the following nerves, right? This took a huge turn. You might have been thinking this was going to be a question about what's wrong with his lung, and what's wrong with his lung, and what is, is it pneumothorax or whatever, one of those answer choices. It's not even asking about that. It changed gears and asked you about the nerve that takes this patient's chest pain and carries it to the brain, right? So with this question, I think they want you to recognize that this patient isn't having chest pain related to the heart, which is the main thing. His chest pain is not due to cardiac related chest pain. They emphasize several rib fractures and a pneumothorax, but they don't indicate any heart damage, right? So lack of adventitious sounds is actually a giveaway for no pulmonary edema. The adventitia is not making any sounds. No pulmonary edema. The pericarditis is what's innervated by the phrenic nerve. And that was a very common answer choice many people wanted to pick. But his heart is fine. There's nothing wrong with his heart. Seeing as how his heart is fine, the fractured ribs are probably what are causing him pain via the intercostal nerves. There was nothing else to really pick here. The other answer choices are just irrelevant. Vagus is also kind of relevant to the heart. It's a parasympathetic nerve. It's not really that significant for sensory stuff, right? So, again, pretty easy question. Not much to think about. Don't think too hard. This wasn't phrenic nerve because it wasn't related to the diaphragm or the heart. If it was related to one of those two things, you would pick phrenic and we'd be done, right? But it wasn't. It was just intercostal nerves because he has rib fractures, and that's why he's feeling pain from. This one, they give you this picture like this, right? And First Aid 2020, actually, let's see. First Aid 2020 started talking about trichotillomania. And, well, they talked about it before too, but in First Aid 2020, they put this image there for trichotillomania. This is from First Aid 2019, already had the text here. In First Aid 2020, they also put the picture there, so I put it into my book. And trichotillomania is compulsively pulling out one's own hair. Causes significant distress and persists despite attempts to stop. Presents with areas of thinning hair or baldness on any area of the body, most commonly the scalp. Incidence highest in childhood but can span all ages. Treatment is psychotherapy, right? And you could give clomipramine, but clomipramine has many side effects, so you don't really prefer that. And that's what this guy has. This is not alopecia. Now, how are you going to differentiate between the two? So let's read this question and figure out how you would see that. 14-year-old girl is brought to the physician by her mother because of a 2-month history of hair loss on her head. The mother says that her daughter has been trying to imitate the hairstyles of several pop music stars by using various ties, rubber bands, and curlers, but she's not sure whether any chemical treatments have been used. Right, it's a 2-month history of hair loss. The mother's making this thing up, right? The mother says that her daughter has been trying to imitate hairstyles. No. The mother reports that the patient has been sad since her grandmother died unexpectedly 3 months ago. Vital signs are normal. Physical exam shows decreased hair density over several irregular patches, temporally and frontally, but no denuded areas, right? No denuded areas. The underlying skin is normal. The remaining hair shafts in these thinned areas are of varying length. There is no frontotemporal recession, which would be the male pattern balding. A photograph of the affected area is shown. Which of the following is the most likely explanation for this patient's hair loss? Alopecia has denuded areas. Alopecia means that you have an autoimmune attack at your hair follicles, and you would have completely bald, flat, tiny areas, right? Not exactly like this, because this is a very low definition picture, if anything. But if you zoomed in, this would not be denuded. It would have baby new hairs coming out, right? Because hair growth is not affected in these patients. Hair growth is fine. Development of new hair is fine, which is why they don't have denuded areas. With no denuded areas, you knock out alopecia areata, you knock out androgenetic alopecia. Androgenetic alopecia would be knocked out also because of no frontotemporal recession. Frontotemporal recession is male pattern balding. That's what androgenetic alopecia is. You knock that out. Telogen effluvium, you've probably never heard of. Tinea capitis would be tinea, and this patient does not have ringworm, so that's not an answer. Trichotillomania makes sense. This is a psychiatric issue, and it falls onto this patient because she's probably stressed out due to her grandmother's death, right? 14-year-olds and young children are often very much attached to their grandparents because grandparents are usually very much attached to young children. As far as telogen effluvium, that's the most common in middle-aged women, so she doesn't even fit the profile. But telogen effluvium is caused from stress. However, this and alopecia would have denuded areas as well. Okay, very important. And then I found this little chart that I put here to help compare. Alopecia areata also has nail pitting, right? And it often presents very similar, looking like someone has iron deficiency. So that's another important side note to remember. Alopecia areata does have nail pitting too, right? All of this is there. And there is treatment for alopecia now, so if you know someone that has issues with alopecia and they want to find treatment for it, you can always send me an email and I can talk more about it. But you can also just check clinicaltrials.gov and you would see that tyrosine kinase inhibitors like tofacitinib, baricitinib, these are effectively fixing and reversing the effects of alopecia. So just a little side note there. Next question, number 17. A 27-year-old preemie-gravid woman at 34 weeks gestation is admitted to the hospital because of nausea and vomiting and abdominal pain for 12 hours. Her pregnancy has been otherwise unremarkable. Prior lab studies, including a complete blood count and serologic tests for HIV and hepatitis, have shown no abnormalities. Her blood pressure now is high. Abdominal exam shows right upper quadrant tenderness. Lab shows very low hemoglobin, right? Hematocrit 24%. Platelet count is also low, should be above 150. Creatinine 1.2, that's kind of significant. AST/ALT elevated, right? Examination of the peripheral blood smear is most likely to show predominance of which of the following in this patient? Well, this is a pregnant woman with nausea and vomiting, abdominal pain, and hypertension. And you know hypertension in a pregnant woman is known as preeclampsia or eclampsia. However, in this scenario, this does not look like it's related to any of that. This is not just eclampsia or preeclampsia, because preeclampsia and eclampsia are only related to two things: hypertension and seizures. But here they're talking about nausea and vomiting and a bunch of other shit. So then you remember the other thing that was on that page, right? And this is why one of the advice I give many people is when you're doing UWorld to study for step 1, you should be cheating, right? Which means you read the question, you might think that the answer is F or whatever. Stay true to yourself. Now go into first aid and check. So you would go into first aid, which is page 701 for this topic. So let's take a look. Right, pregnancy complications, not this page, the next one right after. Right, where did they, or is it, oh, right here, okay. The pages got a little messed up because when I originally did those corrections, I've added more pages into the first aid, so the numbers changed. But hypertension in pregnancy, so it's not preeclampsia because this is really just hypertension, right? And then symptoms of hypertension, but not vomiting and whatnot that patient has, right? And then eclampsia is a more problematic issue, can actually kill the patient, and it has seizures. Neither of those things. So then the only thing that was left is this one, HELLP syndrome, which our patient has. Low hemoglobin because of hemolysis, elevated liver enzymes as we saw, and low platelets as we also saw. There's a reason they gave you all of this, right? You don't need all of this lab values for eclampsia and preeclampsia. Not important at all, right? Normal platelet count is 150 to 400K roughly. This is below that, half of normal, half of 150, right? Elevated liver enzymes, all of that reminds you of HELLP syndrome. Now you create a mental network of things that are related to each other because they're all on the same page. And anytime you get a question on it, you remember all of it. The more you study in that manner by cheating on UWorld, the better you develop that kind of networking of pages and topics on a page. So since this is just HELLP syndrome and you remember hemolysis, hemolysis has schistocytes, D. You just move on. And for this patient, it would be best to deliver the baby as soon as possible. It's been 34 weeks, so it should be okay. There's been a picture for every image so far. Every question so far. 18. While lifting weights, a 24-year-old man develops a painful swelling in the right inguinal region that cannot be reduced. Very obvious what's happening to him. The photograph shows a segment of the small intestine resected at exploratory laparotomy. Which of the following is most likely diagnosis? Right, so what happened to this segment? So this must have been the segment that kind of herniated and it got strangulated in that herniation, didn't get enough blood supply and kind of died off. Right, which is why you're seeing the darkening here and the paleness here. Right, whereas this area is looking normal, here is looking kind of normal. None of the other things. It wasn't an adhesion. Definitely wasn't an embolism, although the same image could be used for embolism questions also if you change around the question, change the wording of the question. It's not intussusception. That would have to have a target lesion of things going into each other. And it's not a volvulus, which would be twisting. Right? This person had a hernia. The inguinal part of the question points you to a femoral hernia. Right? What? Not exactly a femoral hernia. Oh, inguinal region. Okay. Yeah, so uncommon type of inguinal hernia in which intra-abdominal contents herniate into the femoral canal through the femoral ring. The image, strangulation, ischemic necrosis of contents within the hernia sac as blood flow is compromised due to incarceration. Right? So in short, femoral hernia can lead to a complication called incarceration, which can lead to strangulation. I'm not 100% sure right now, though. I don't know when I wrote this, but I'm not 100% sure if this is a femoral hernia, though. Because femoral hernia occurs in females, right? So let's just take a look at 401. This guy was lifting weights, and lifting weights can also cause an indirect inguinal hernia, which could theoretically also cause strangulation of that portion that went in. You see, this portion that, let me make this bigger. This little portion here that went into into the scrotum could also get strangulated right here. Not going to get the correct blood supply if there's strangulation at this region right here, and this is the stuff they would kind of rip out during the laparotomy, and that's what you're seeing here. Right, so let me just add that here actually. However, considering this is a man, it was probably an indirect inguinal hernia and had strangulation of the portion that went into the scrotum. Right, so that's more likely what's happening, just to be complete. I'll put this here too. All right. Anyway, pretty straightforward question again. Like none of these questions so far have been excruciatingly tough, so that's a good point. And again, if you're ready for NBME, look, we're only up to number 19. Right, so you really shouldn't be having trouble with any questions at all. You're really just allowed to get, at a maximum, I think you can get 10 questions wrong total and score really well. So that's kind of what you want to aim for. And 10 questions total kind of means within these 4 sections, like you're getting at most 2 to 3 wrong per section. This question is one you can get wrong. Right, this is a bullshit question that you've never probably heard of. They gave you this, which is nice of them. So it tells you something, it has some information you've probably never heard of too. They go on to tell you a 5-year-old boy is brought to the physician for a well child examination, recently immigrated to the USA from Nigeria with his parents. He has no history of major medical illness. He's at 40th percentile for height and weight. His vital signs are within normal limits. Physical exam shows red bronze skin, red hair, and continual horizontal nystagmus, which is weird, right? Something's wrong neurologically. Lab studies show a complete blood count that is within reference range and normal leukocyte and platelet morphology. Genetic testing shows compound heterozygosity of the TYRP1 gene, right? In the figure shown with presence of both a frame shift and a nonsense mutation. Right, so TYRP1 is right here, and there's a frame shift mutation in it and a nonsense mutation in it, okay? These genetic changes most likely cause which of the following in this patient? And you look at all your answer choices. Absence of tyrosinase. Tyrosinase deficiency would be a whole different thing. Now what's happening with this patient? Decreased concentrations of 5,6-hydroxyindo-2-carboxylic acid. For this, you would refer back to the question, right? All of these. If you didn't have tyrosinase, you wouldn't make any of these things, and that's not what's wrong with our patient. If you don't have this, that would mean that your TYRP2 is not working, and that's not true for our patient. His TYRP2 is working, so he's definitely making this. Decreased reactive oxygen species in pigment and cells. There's no reason for reactive oxygen species to not be working. That's something that's more so related to chronic granulomatous disease and NADPH oxidase. Irrelevant here. C doesn't make sense. Increased photoprotection of the prevalent melanin form, or lack of choroidal pigment deposition in the macula, which was the correct answer. Now, picking between D and E is something that would really come off of your own understanding of medicine and understanding of this patient's question over here. Process of elimination for this one. A and B you can eliminate immediately, but just by looking at this biochemical pathway. The other two required knowledge that eumelanin is more protective than pheomelanin, and this is something that you would not know very well. But redheads, people that are redheads, right? They actually get sunburn and burns in general from UV radiation much more easily, right? Pheomelanin. Eumelanin is true melanin, which you and I all have with our black hair and black eyes and whatnot. That is actually more protective, right? And when you don't have TYRP1, you're not gonna make eumelanin, right? Because that's what they told you in the question. In the question, they said you have a mutation of TYRP1 gene, so that means your TYRP1 is not working, so you're not gonna make eumelanin. They didn't put that as an answer choice. Had they written, you're not going to make eumelanin, that would be the correct answer choice, and you would pick it and you would move on. They didn't do that. Lack of choroidal pigment, deposition in the macula, which is obviously usually black, would basically be what they're saying here, right? Lack of black pigment. Okay, so that's what happens. Increased photoprotection of the prevalent melanin form is not true, because that's exactly the opposite of what's going to happen. This is protective, and you're not going to have increased photoprotection, because you're not going to have increased production of that either. It's very important to understand that aspect. You could also knock this answer choice out because nothing would be increased. Why would you make more of anything? You just have a mutation where you're making less of something, and you're making less of this. From this given diagram, you can understand that you're going to be making less of this. That's it. The bones of the hand, right? So very obvious one. You want to make sure you're able to name all of them. The wrist bones, name all of them using the mnemonic that's given in the book. Oh, someone asked a question. Doesn't indirect commonly occur in pediatric groups? Yes, it does occur commonly in pediatric groups, but this is also the same herniation you can get from lifting weights. Lifting weights, again, depends on how weak your processus vaginalis is. If it's very, very weak, then you can have this issue in younger kids. But as a grown adult, if it's weak enough, lifting weights, the pressure that it causes can cause an indirect inguinal hernia. Thankfully for us, for that question, they didn't ask about inguinal hernias. Salam is saying, I think it's impossible for me to just get 3-4 rounds only per section. Haven't done any games this yet. Any tip how I can speed up review even at least one round in start NBMEs? Yeah, I mean, In general, that is the cutoff though. You definitely don't want to get more than 2 to 3 wrong per section to score very, like you want to be happy with your score. You don't want to get more than 2 to 3 wrong per block. And as far as I'm seeing right here, I wouldn't have gotten any of these wrong so far. There's just no reason to. I would get all of these correct because all these questions have been pretty straightforward. Even this question, which is, bullshitty because it's not really something straight out of first aid, I was able to figure this out. Remember that when I write these explanations, I look at each question myself, I try to see what I would pick, and then I try to find out what the correct explanation is and whatnot. And I tell you guys which ones I didn't get wrong, right? So that's something I also do, and then I explain what else is happening in a question. Very important to make sure that you get minimum questions wrong if you want to score well, right? That goes without saying. So far, there hasn't been anything that was so excruciatingly confusing that you would get it wrong. And even this was a very good question. Very easy, straightforward question about musculoskeletal bones of the wrist, right? So this, you want to be able to name all of these very easily, right? No matter what you use. You could use this mnemonic, scaphoid to trapezium, so long to pinky, here comes the thumb. It works very well. And here you would do the same thing, so long to pinky, so comes the thumb. This is your, the radius and the ulna, so this is your radius, the bigger one. Right, so you start from the radius part. Remember that the radius is the part where the thumb is, right? So with the thumb, so you would go from here, so long to pinky, so here comes the thumb, right? And by doing so, you'd be able to figure out the naming of the bones. So then they tell you 19-year-old woman is brought to the emergency department 30 minutes after falling on her outstretched right hand during a gymnastics competition. Physical exam shows tenderness of the anatomical snuff box. An x-ray of the right wrist is shown. The most likely diagnosis is fracture of which of the following carpal bones? Okay. Sorry, guys. All right. So, physical exam shows tenderness in the anatomical snuff box, and this snuff box part was kind of the giveaway what's wrong with this patient, right? So you have the snuff box right here, which is what they're showing you. That's your radial side, right, with the thumb side. And you have to remember which bones are related to which issue, all right? So I'm showing you all of these kind of right here. So scaphoid and lunate are discussed right here, right? Scaphoid is the most commonly fractured carpal bone, typically due to a fall in the outstretched hand like our patient. Complications of proximal scaphoid fractures are avascular necrosis and non-union, right? And that's what we're seeing right here. Because the blood vessels that go in this area, right, the radial artery, branches of it can get messed up and damaged. Fracture not always seen on initial x-ray. Dislocation of the lunate may cause acute carpal tunnel syndrome. Right, those are two things that they've discussed right here. And I think later on in this was, what is this? This is the anatomy and physiology. So in path, later on in path, they show you that, right? They tell you about carpal tunnel syndrome, right? This one is related to the lunate bone. Lunate bone. So our patient, for our question, was straightforward, just scaphoid. It was super easy. This is the easiest way to ask a question about the scaphoid. Like, it couldn't be anything else. Right? The floor is formed by the scaphoid bone, and it is here that one can palpate for a possible fractured scaphoid. Right? You didn't even need the picture. The question itself was enough. Here, another image, another question on the same image again. Right? Remember A over here? That was your caudate for the Huntington question earlier. So, seeing the question twice. I think they have a pool of questions. Each NBME is 200 questions, so I'm sure they have like a pool of maybe 1,000 questions from which they randomly select 200 questions and make a test. Right? So in that way, it's definitely very obviously possible to repeat questions. Yes, I do think they do that, something like that. And of course, I'm sure they try making new questions every once in a while too, but again, they still use the pool also, so questions get repeated. A 66-year-old right-handed woman develops the acute onset of spastic left hemiparesis and weakness of the lower two-thirds of the face on the left. The most likely cause of her condition is a lesion in which of the following labeled areas on the MRI of the brain. So again, look at this. This is a patient with a pure motor issue, right? They're not mentioning anything sensory per se, okay? And this is related to your motor neuron signs, right? So here the answer was B. And look at this. First of all, B and E are the only options on the right side of the brain. That's one thing. Right? They told you that she has left hemiparesis and weakness of the lower 2/3 of the face on the left. So B and E were the only things that are on the right side. Sorry, on the left side. No, what am I saying here? Why did I pick right side? Excuse me. This is supposed to be left side because it's back to left hemiparesis and weakness of the lower. Yeah, it's the face. It's when it's the face, it's usually the same side, right? Because the decussation hasn't occurred here. But let me just read this first anyway. They labeled it, but in general, remember that these images have you looking at the patient from their feet, right? This is the left, this is the right. Right, okay, and this spastic paralysis is an upper motor neuron lesion, which should immediately make you think of an internal capsule stroke, and that's what B was. So one thing also for such images, I don't really think it often matters which side you're talking about, because although they labeled this here, right, B, this could also just be saying that is it a damage of the internal capsule or not, because this is also your internal capsule of the other side, right? So whether it's left or right doesn't necessarily matter unless they labeled both things. Like if they had another answer choice here saying this is maybe E, right? So they didn't do that. They only labeled each thing in one side. And this B must be here rather than here simply because they didn't want to, put everything onto one side or whatever. Either way, B and E are the only options that are on the right side of the brain here, right? Because this is your left side. And this is an internal capsule stroke. It's a pure motor stroke. If we go to page 573, we can see that. And that's something that you have to be ready with, right? So motor neuron signs. Wait, one more thing though. Let me just check. Yeah, this thing, facial nerve palsy. So you can see how this is happening here too, right? Usually same side stuff. Okay, usually same side stuff, but it can be opposite side too. And that's something that you have to study more in depth to get better at. But it was just an internal capsule stroke. Very common question. You can see some of these other questions here from UWorld. Again, asking about the internal capsule, which was labeled B here. Right, this 62-year-old woman came for a left arm clumsiness. Physical exam reveals motor weakness involving the left arm and leg. His speech is slurred and drooping of the lower face. Right, on passive extension, there's initial resistance, then sudden release, which is known as a clasp knife. Right, clasp knife has a sudden release. It's usually closed and then it just clicks open very suddenly, not slowly and nicely. So clasp knife spasticity, all of these things were a sign of internal capsule, B, right? The internal capsule. And another way to look at the internal capsule is this area right here. A very commonly tested section. Very big deal. Make sure you know it. Don't forget that stuff at all. What are we up to now? 22. Okay, 3 more and then we're done. So 26-year-old woman, which is labeled person 3-2. So person 3-2, this one right here, okay? This patient right here. Yeah, Nitin, that's exactly what it is actually. I'm a little tired now. I'm like really, I don't want to do any more, but we'll finish 25. But yes, lower, so the forehead is spared. That's exactly why it would be right side anyway. But also because you wouldn't pick caudate, you wouldn't pick the C or the D. There's no reason for it to be any outer part of the brain over here either. So none of those made sense. E is more for visual issues back here. So that wouldn't fit either. Alright, so 28-year-old woman, which is 3-2 over here, comes to the physician for counseling prior to conception. Many members of her family had blistering of the skin in infancy and now have unusual marbled pigmentation of the skin. The underlying inherited condition is uniformly fatal to males in utero. So any man that gets it immediately dies, which is why all these boxes are people that got the disease and died, right? Those are men. A pedigree is shown, which of the following is the most likely risk that this patient's live-born offspring will be affected, right? So you can see from the first generation given here that these guys had 1, 2, 3, 4, 5, 6 kids. 6 kids, of which one of the daughters got it, right? This family here now you can see since no one here got it, none of them got it either. None of their kids have it. But since this daughter got it, when she married a man who didn't have the disease, because again, if a man has it, they die. She married a man, had a ton of kids for whatever reason, and it almost looks like a half-half thing, right? So of all the daughters, only 2 daughters didn't get it, 4 daughters did get it. Of all the sons, only 2 sons didn't get it, and 3 sons did get it, and they died. Okay, so that's basically the only breakdown you're seeing here. Now, the question asks about live-born offspring, right? Which of the following is the most likely risk that this patient's live-born offspring will be affected? Very important thing to catch. Which means that they're basically saying that they're going to have a live-born offspring being either a male that didn't get anything or a female. Right? A female is going to be live-born even if they have the disease. But they want to know affected, right? So if a live-born offspring is affected, that means that they're definitely going to have a female, right? So 0 males will be born affected. The disease is given from the mother to males and females relatively equally, so it must be X-linked dominant. That's how you come down to that evaluation, right? Because first thing you have to do is figure out the pattern of the disease being spread. Is it autosomal recessive, dominant, mitochondrial? Mitochondrial would be evident because the mother would give it to all her sons, as well as a couple of the daughters, right? Everyone would be getting it because you get your mitochondria from your mom, no matter what. So the mother would give it to all the kids, regardless of anything, and there are some kids that don't have it, so that would make no sense, right? X-linked recessive versus X-linked dominant is a whole different deal. X-linked recessive, remember that the son gets his X from the mother, and depending on which X he got, he would or would not have disease, something like that. Moms have 2 X's, right? And as having 2 X's, the mom can pass a normal X or a bad X to all her kids. And that's all that's happening here. To some of the kids, she gave her good X chromosome. To some of the kids, she gave her bad X chromosome. The sons that got the bad X chromosome died. The sons that got the good X chromosome lived. That's all you're seeing here, right? This is not autosomal dominant or autosomal recessive either, because you have to remember autosomal recessive is usually enzymatic deficiencies. And autosomal dominant would look pretty similar, but the reason you wouldn't pick autosomal dominant is because up here, right? Up here, they had many kids and only one of them got it. Right? Very different from an X-linked dominant kind of thing. So now you look at all your answer choices, and D is the only one. 50% in females, but near 0 in males. Right? Near 0 you had to pick an answer choice that said near 0 in males because live-born offspring that is affected cannot be male. Cannot be male, right? This was a slightly difficult question, and this was one that I got wrong. Right? I got this wrong. I wasn't entirely sure what was happening here. I was able to come down to the fact that it would be X-linked dominant. I did get that part down. And I didn't know. Later on, I checked and found out that this description that they're talking about here with marbled pigmentation of the skin, this is a disease called incontinentia pigmenti, which is an X-linked dominant disorder that affects skin, hair, teeth, nails, and CNS. But the 50% in females and near 0 in males should have been something I was able to get right once I figured out it's X-linked dominant, right? Because the chances of passing your X chromosome is 50-50. You either get the good one or the bad one. I actually went with 25% in females, but near 0 in males. I'm not exactly 100% sure anymore why I picked that, but I do remember picking A. So this was a question that I got wrong. And something like this, you can get wrong. It's okay. Right? Because everything else, assuming everything else that you got right, getting something like that wrong is not so bad. This is a question you can't get wrong either. You see this and you should know this is a cavernous sinus. You should immediately be able to remember what all of those nerves are, especially which one C is. And then you read the question and you figure out what's wrong. So they tell you 65-year-old woman undergoes surgical repair of an aneurysm of the right internal carotid artery in the cavernous sinus, which is this one right here. 3 days later, physical exam shows that the right pupil is larger than the left pupil. So the right pupil is dilated. There is also weakness with movement of the eye. A diagram of the coronal section through the middle cranial fossa of the cavernous sinus and associated structures is shown. Which of the labeled nerves is most likely damaged in this patient? Now, here the answer was A. Right, page 587 discusses it, and let's figure out what's happening. So page 587, right, with the eye-related stuff, cavernous sinus right here. Right, so you have your oculomotor nerve, right, trochlear, and you should be able to do that immediately, right? So 3, 4, V1, V2, and then over here, this is your 6. And when you see this picture, you should have been able to fit 3, 4, V1, V2, 6. Okay, you have to remember that. And the blown pupil is a cranial nerve 3 thing, right? The abducens nerve is actually the nerve most likely damaged by expanding internal carotid aneurysm, but they didn't give you enough information to pick the abducens nerve, right? Normally when this thing expands, it hits this cranial nerve 6 and causes other issues related to abducens nerve. That didn't happen. C is the abducens nerve, cranial nerve 6, while the others are, as we said, 3, 4, V1, V2. Cavernous sinus syndrome presents with variable ophthalmoplegia depending on which nerve is involved, and it can also have Horner syndrome and other things. Our patient is presenting with a blown out pupil, which is due to cranial nerve 3. Right, cranial nerve 3, remember, has 2 parts to it, right? It has the outer and inner part. So having a down and out blown pupil is related to it. The outer part is parasympathetic, the inner part is motor output, and you have to remember what's happening. So most likely for our patient, the outer part got compressed. The outer part got compressed, and parasympathetic issues are causing a down and out gaze with the blown pupil. All right, so not so bad at all. 24, you should immediately recognize this is a glomerulus. 54-year-old man comes to the physician for a routine health maintenance exam. Pulse is 80 per minute. Respirations are 14 per minute. Blood pressure is pretty high. Physical exam shows no other abnormalities. Angiotensin 1 converting enzyme inhibitor, an ACE inhibitor like enalapril, is prescribed. Which of the following labeled regions in the illustration of the kidney shown will be most affected by the administration of this drug? And you have to remember, ACE, angiotensin constricts efferent. An ACE inhibitor will stop that. Okay, so the answer was F. No matter what, the efferent will be the one that's affected. You stop the constriction of the efferent, so now the efferent will dilate a little, right, allowing you to have better blood pressure control, sort of. Okay. Whereas prostaglandins, remember PDA, prostaglandins dilate the afferent. So if you're taking too many anti-prostaglandin medications like NSAIDs, you can no longer dilate the afferent, and that can also cause renal injury. Right? It's renal protective to have PDAs working, prostaglandins working, so you don't want to mess that up. This question is another one many people could get wrong theoretically, but it was actually a pretty good and easy question. You didn't necessarily need to calculate anything, but there was a lot to read, and it does look a little intimidating. So we'll do this, and then we'll call it a day for now. A study is conducted on patients with asthma to compare a new asthma treatment with a placebo. After 12 weeks of therapy, the mean, plus or minus standard error of the mean, symptom scores were 2.8 plus or minus 0.1 in the treated group, with 103 people being treated, right, N is the number of people, as compared to 3.1 plus or minus 0.1 in the placebo group, with 100 people being in the placebo group. The p-value is 0.035, which is less than 0.05, so that's good. The investigators of the study state that they chose a sample size of about 100 subjects in each group to have an 80% power of detecting a mean difference of 0.4 at a significance level of 5%. So since the p-value is less than 0.05, all the information we see, we know that it wasn't purely by chance. That's what p tells us. P tells us that the data we've collected, it was not purely by chance, right? And this kind of question is very important because as a doctor, you could do clinical research, which is relevant to the new job I got, right? I'm a clinical research coordinator now, and I help doctors to get the data so they can actually see if the research they're conducting is working or not, basically. So here we're trying to figure out, is this working or not? When planning a study, which of the following is the meaning of 80% power? That's all they wanted to know. 80% power. What does this 80% power mean? Well, remember, power was your beta error relevant stuff, right? What was beta error? Beta error was relevant to kind of not rejecting the null hypothesis when you should, right? Blindly letting go of a criminal, something like that. So what is 80% power telling you? And then you read all your answer choices, and you could take your time reading it, but 80% power means exactly what it says in answer choice F. If the treatment really changes the mean asthma score by 0.4, there's an 80% chance that a study of this size will find a value less than 0.05, which means that if this treatment actually helps an asthmatic person, there's an 80% chance that that occurred because it's actually true, right? Because it's actually true. That is not just by chance. Being by chance would mean that a p-value of more than 0.05, right? But this would be not just by chance. Very interestingly worded question, but it really tests you on how well you grasp the understanding of p-values, beta errors, power, and all of that other stuff with the null hypothesis and alternative hypothesis. You want to make sure you know this very well for the NBME, because NBME does test you a lot on biostatistics and epidemiology and ethics, those three things, as well as even Vmax and efficacy and potency. But I haven't seen so much of that, not so much pharmacology. But biostats and epi and ethics are a huge part of NBME, where people end up losing out a lot of points and performing badly, even though they were ready with the pathophysiology of all the other stuff, right? So very important to make sure that you spend ample time grasping this the week before your actual NBME is, all right? So we're going to stop here at question 25. We'll do numbers 26 to 50 in the next video. Thank you very much for joining. We'll keep going. I'll be live again tomorrow sometime around, same thing again, 7 to 9 p.m. NYC time, Eastern time, Eastern time, USA. So yeah, thank you very much. Make sure you subscribe, turn on notifications so you know when I'm live, and I'll see you guys tomorrow.